If you remember, this time we're going to talk about some of the structures and legislation that underpin the Public Health Emergency Preparedness and Response, or PHEPR system. That's the Public Health Emergency Preparedness and Response, or PHEPR system. This time I am going to show some slides, so be ready for them. Here we go. Just to kind of recap, we started off last time looking at the history of public health preparedness and the events we have. This is a chart by Dr. Jen Horney, used to be at UNC, now at Delaware, of the public health events, many of which we talked about last time, and some of the preparedness policy and legislation that was put in place. So you'll see the Public Health Threat and Emergencies Act kicked that off in the year 2000. After 2001, you had the Frisch-Kennedy Bioterrorism Preparedness Act. So that's the act that created the PHEP system that we're going to talk about, as well as the Hospital Preparedness Program system that we're going to talk about. And those were followed later in 2006 by the Pandemic and All Hazards Preparedness Act, which is post-Katrina and kind of consolidated a lot of these reforms in place. That was reauthorized and then re-upped again in 2019 as the Preparedness and All Hazards Preparedness and Advancing Innovation Act. I don't know how to pronounce that, but I think it is PAPAYA, and I'm not kidding about that. The PAPAYA Act moved especially hospital preparedness forward and tried to put in place evidence-based benchmarks for the work. So this is sort of your historical framing. You can find this image if you want it in the reading that was assigned from the National Academies before that, and that's going to anchor some of the analysis I'm going to do. Anyway, when you're looking at the systems and structures of public health emergency management, there are really two systems you have to take into account. The CDC and their public health emergency preparedness focus on cities, states, territories, building up the public health infrastructure there. And the Assistant Secretary for Preparedness and Response within Health and Human Services, called ASPR, which runs the Hospital Preparedness Program, now the Healthcare Preparedness Program, which is focused on sort of the medical side of this. So you have a public health side under CDC, a medical side under ASPR, both of them under the Department of Health and Human Services. Now, this leads to some back and forth. Something like the Strategic National Stockpile that we talked about last time originated under CDC, moved to ASPR, moved back to CDC. I think it was at FEMA for a while, back to CDC, is now again, as of the last year or so, in ASPR. That's where it was for COVID. Anyway, in this lecture, I'm going to talk about the CDC sort of grounding, and I'm going to talk about the ASPR grounding. So CDC first. So the way CDC conceptualizes public health emergency preparedness is through a set of 15 capabilities, the public health emergency preparedness capabilities, that are put into 6 domains. You can see them here: community resilience, incident management, information management, countermeasures and mitigation, surge management, and biosurveillance. Biosurveillance covers epidemiology, laboratory testing and diagnostics. Countermeasures, pretty obvious, medical countermeasures, also non-pharmaceutical countermeasures like quarantine, active monitoring, the stuff we've talked about a lot in COVID. Incident management is your ICS structure. Community resilience is sort of the CDC's attempt at a whole community approach from an emergency management standpoint, but it focuses on community outreach, community cohesion, and community partnerships to try and integrate sort of the rest of the aspects of the community into the public health response. Surge management is when we're looking at medical surge in particular. That capability ties into the ASPR capabilities we'll look at in a little while. So these have changed over time. Public health emergency preparedness was really conceptualized in 2007 as one bucket, right? Pulling together these legislations by Nikki Lurie, who was at that time the Assistant Secretary for Preparedness and Response. Sorry, I'm talking about 2009, not 2007. Feel free to scribble that out in your notes. Nikki Lurie came in with Obama, conceptualized public health emergency preparedness. In 2011, then these capabilities were developed for the first time, along with a set of healthcare capabilities that came out in 2012. That was the initial sort of real grounding of what we were talking about in terms of the functions and capabilities of it. Similar, and at the same time scale of when FEMA was putting out their sort of capability-based approach, the National Response Framework were being upgraded, all that stuff. So the thing about these capabilities is they are a little all over the place from an emergency management perspective. Of the 15 capabilities, 3 of them are really preparedness based. Community preparedness, for example, is preparedness driven, whereas others, incident management, are response based. They sort of conflate the phases in emergency management in confusing ways. Also, there's some things they leave out: environmental health, mental and behavioral health, things that we think of as core public health practice were excluded from those capabilities. They were brought in a 2018 update, but not as full capabilities, kind of as like sidebars that were stitched throughout. It's kind of confusing because we think of them as core public health functions. But it speaks to a way that sort of the medical and core public health professions, epidemiology, diagnostics, really were thought of as central, even as Katrina, even as Zika were showing how important environmental health, mental and behavioral health were. So there's still kind of an imbalance in the field, almost like a segregation of functions that happens within the capability. Also, they don't have a way to show the capabilities needed to run the response itself. So if you look back to disaster sociology, I'm talking about Dines or Quarantelli, those guys, they'll tell you that there are 2 aspects that are important to running a response: the focus on the incident and a focus on the response itself. The focus on the incident are your kind of outward facing objectives, right? The objectives that are doing work in the world. In the case of public health, that's like epidemiology, countermeasures, that kind of stuff. But Quarantelli and others said there were also a set of objectives that were internal facing, response objectives, the objectives you needed to follow to kind of feed the beast, keep the response going. Planning section objectives, putting out incident action plans, logistics driven objectives, getting resources, paying for stuff. Those sorts of things are not really conceptualized or focused on in public health emergency preparedness. And these capabilities have had to do a lot of work grounding those, a whole focus on administrative preparedness and grant making and all this other stuff. Whereas from an emergency management perspective, what you need to do is equalize all of these types of capabilities so they're at the same level, same kind of focus. So that's your basic step grounding. The National Academy of Sciences, Engineering, and Medicine came out with evidence-based practice for public health emergency preparedness and response. This year, I briefed the NACCHO Prep Summit on it a few weeks ago. And I'm lifting up for you now because it shows that one of the problems with public health emergency preparedness has been that a lot of this stuff we're talking about in terms of capabilities and other aspects have never been studied. There isn't an evidence base. We went through, as a part of this committee with the National Academy, 1,600 different articles in the last 2 decades looking for evidence that these capabilities did good in the world, right? That they actually accomplished things in an emergency. Of those 1,600 articles, only 72 of them were actual studies about public health capabilities. And of those, only 15 of them looked at them in a response. The other articles were looking at trainings or exercises, stuff like that. So what we found is there was not a lot of evidence for this work. CDC, although it's a research-driven entity, hadn't been able to fund and sustain the kind of research we need to actually know what needs to be done in a public health emergency. So some of the things that I'm previewing the next talk a little bit, but some of the issues we saw about mask, lab testing, those sorts of things, they were actually studied and concluded in other parts of the world. The United States was really a step behind in terms of research. But we did find and were able to determine a few things about public health emergency response. One of them actually pains me, which is that there's not enough evidence out there to show that Public Health Emergency Operations Center that we talked about in the last talk at CDC does any good in the world. In fact, there isn't any evidence out there since the year 2000 that an emergency operations center in general does any good in the world. That is not to say it doesn't. I'm a firm believer in emergency operations centers. And just a thumbnail, if you haven't covered these yet, an emergency operations center is a place where you coordinate large systemic operations. So you might have at a fire, something like that, an incident command post in the field that's coordinating tactical operations. You may have a few of those. At a jurisdictional level, the jurisdiction will put an EOC in place to make sure that multiple incident command posts can be supported, that operations are coordinated between different agencies within government. It's a whole host of things like that. So looking through all these thousands of articles, there was insufficient evidence to determine whether activating a public health emergency operations center was effective or not. It doesn't mean it's not effective. This is what's tricky about this research. It just means nobody studied it and found out anything. But a few things we did find out about emergency operations centers. And this is important because there are best practices out there that you, as people learning to be emergency managers, should know. So we don't know in general if an EOC helps. I guess that's the caveat. But let's assume it does. We know that it should be activated when an emergency is large and complex. When something's novel, that is when something's new, because that will usually involve new tasks and new partnerships. Some event that requires public health support functions, we need it, something like that. Resource, cost, technical, legal, and logistical constraints need to be overcome, and you need a high level of interagency partnership. So those are the places an emergency operations center is supposed to shine. Now, if the cost of activating that EOC is higher than the cost of the resource needs for the emergency, that's a good sign not to activate it. If something's going to be quick and cheap, maybe you don't need an EOC. How do you activate it? Well, here are a couple of important points. Trust the judgment of folks who have been in emergencies before. A lot of times in an agency, you'll have some high mucky muck up here, a lot of people who've been through the grinder before of an emergency. And the high mucky muck will be resistant to activating. People who have been through it will say, we really need an emergency operations center. The evidence shows that you listen to those folks who have been through it. You have to respect that knowledge. And also, mobilizing sooner is always better than mobilizing later. So if you're going to do it, it's better to sort of call the shot early on because you get more benefit that way. So that's kind of a sample of what we learned about EOC. The other thing that is grounding the underlying public health emergency preparedness now that I want to focus on are the results of quarantine, because that's something we've heard a lot about during COVID. So quarantine, there's good sort of certainty of evidence that quarantine can be effective in certain circumstances. That is, if it's early on in an emergency and, folks are coming in, you don't really know what you're dealing with, you don't have a way to treat it, you can quarantine people that have been close contacts with people with the disease, get them out of the way, keep them locked up so they don't spread the disease further. It is best early on. There are also substantial undesirable effects. If you quarantine folks in a congregate setting, like they're all in a hotel, they will often spread it to each other. There's psychological harms. It involves all of this sort of anxiety and stress. And there's individual financial hardship. Certainly, we've seen that in COVID. The financial havoc that the lockdown has reached has been extraordinary. So we recommended, this National Academy Committee, that you needed really frequent risk communication. It needed to be really grounded, and you needed things like employment leave and help with financial duties. So at the end of it, quarantine, there's evidence that it is effective in slowing and stopping diseases. It only works until you have a vaccine or treatment. And it's not as effective as things like active monitoring. If you have contact tracers who are calling people every day to check on them, that's something that's less resource intensive, but just about as effective in quarantine. So the whole idea of a quarantine lockdown is that you do it for a limited amount of time while you're building up the kind of test, trace, isolate muscle that we talked about last time that stopped Ebola, right? So the quarantine lockdown is an intermediate set of things you do because of the harm that's involved while you're setting up this test, tracing, and isolation structure. Another kind of COVID spoiler is that because we never set up that structure nationally, we sort of wasted the time that we have put in quarantine and have caused more harm than we otherwise needed to. So when do you do quarantine? Based on the evidence, and most of this evidence comes from SARS, MERS, SARS being a respiratory syndrome that hit Toronto, Hong Kong, MERS, a similar syndrome that came from the Middle East. Early in the outbreak, when there's a shortage of countermeasures, you sort of weigh the resources against the benefits. You want the R naught to be in a range where quarantine can importantly reduce transmission. So the R naught is the infectious nature of the disease. Is it really infectious or a little bit infectious? If it's really infectious, quarantine may not help you too much, because by the time you quarantine somebody, they're infected, you're infected, everybody's getting infected. Measles is a good example of that. If something is asymptomatic for a few days and you are contagious while you're asymptomatic, that's a good target for quarantine. That's what COVID shows us, but that's also what quarantine is good for, because you are keeping folks out when symptom checks aren't really going to help you. A person may not have a fever, but they're infectious. Quarantine, bingo, might be a good idea at that point. And you want to make sure that when you do it in legally enforced ways. You do it voluntarily, if at all possible, because that's going to keep people from fighting against it. And you make sure that you protect people from civil rights and harms. So there's a lot of complexity around quarantine. It's a difficult thing to implement, and we've seen that during COVID in all of these different ways it's been implemented. But it is kind of a key piece of the public health toolbox. So I'm showing you these two things as samples of the kind of evidence that underlie, or that either underlies or doesn't underlie, as we saw in the case of the Emergency Operations Center, the different capabilities that are within FEP. If you're interested in this, you can go to the National Academy's website. You can Google their FEPR report, and it has sort of one-page breakdowns of the key findings that are written for practitioners. I find them really helpful. They distill all this evidence down to just a few key recommendations for practice. Really helpful if you're in a public health emergency response in terms of the current state of the FEPR capabilities. The other thing that I want to highlight is the National Academies also came out with what they call an optimal public health emergency preparedness and response system. For me, this is something like the FEP capabilities 2.0. So we talked a few minutes ago about the 15 FEP capabilities, and some of them are preparedness, some are response. They don't really cover the underlying stuff like planning and logistics that you need to think about in an EOC. Well, this model is much better. If you look at this model that came from this National Academy Consensus Committee, it's clear to see that you've got the things that you're doing to support your agency response in terms of knowledge of threats, decision-making, administrative preparedness, as well as the things that you're doing to manage the public health threat. So that's your warnings, your lab tests, your treatments, your vaccinations, all that kind of stuff. And at the same time, if you look at your screen on the left, there are sort of process outcomes that are specific to preparedness. So do you have a resilient community? Have you put systems in infrastructure in place? And then on the other side, on the right, process outcomes related to response. This is what you're actually trying to do. You're trying to make sure there's equity, you limit disease spread, you minimize social disruptions, you're minimizing infrastructure damage, mortality, morbidity, all that kind of stuff. And there's some keys for how you evaluate that. You have to look at the ethical considerations. We'll look at those in the fourth talk. You have to look at political, demographic, geographical vulnerabilities. You have to look at the differences in vulnerability. Certainly in COVID, we've seen that the disparities we see in health outcomes generally, where people of color are more likely to have shorter lifespans, and that there are other sort of underlying chronic conditions that are there, usually because of lack of healthcare access. Those things have increased the COVID mortality rate. So the vulnerabilities we see every day certainly impact emergency deaths. That's not specific to public health. We see that in hurricanes and earthquakes too, that the people who are most vulnerable day to day are most vulnerable in emergencies. So at the end of the day, here's the public health preparedness and response FEPR system as it's developed to this point. This is the result of the story that I kind of told you in the last lecture. And in between it all, there's this knowledge, decision, and action loop that has to run quickly so that you're making a decision. You're carrying out the objective of that decision. So you make a decision about how you're going to do lab testing. You carry out those lab tests. You have to evaluate how well it's working. You have to get in additional resources, change your plan up, and then you got to do it over and over again. It's kind of a hyper version of the planning P in the emergency management cycle, except it's not just one cycle. It's a number of different linked cycles at different levels of public health and medical systems, all kind of coming together. So that's the CDC public health side. Now we're going to switch over and talk about the ASPR healthcare preparedness side. I'm going to drink some water before I do that. So if you remember, I talked about in 2009, Nikki Lurie wrote an editorial in the American Journal of Public Health laying out what public health emergency preparedness was. Out of that work in the Obama administration came the FEP capabilities that I talked about, but also a new set of hospital preparedness capabilities, now healthcare preparedness capabilities that were developed within the Assistant Secretary for Preparedness and Response at HHS. That started out as like a tiny little medical coordination office, but between H1N1 and COVID, it is kind of extraordinarily grown. And it is really the tactical seat of medical response for the country. So I asked you to watch a video about the Javits Center. ASPR is the group that coordinates field medical teams. They coordinate the dissemination of medical material. They can set up federal medical stations, multiple 100-bed facilities like you saw at Javits. They also coordinate disaster medical assistance teams. So those are drop-in teams of 30 or 35 folks, kind of a clinic-in-the-box teams. And they also coordinate ESAR VIP, which is a coordinated set of voluntary health professionals state to state, so people that volunteer to surge the response. All of that stuff comes out of ASPR. ASPR also coordinates something called PHMSE, the Public Health Emergency Medical Countermeasures Enterprise. The federal government spends billions of dollars every year to develop new pharmaceuticals that might be useful in a pandemic or other emergency. ASPR kind of chairs that group, the NIH, the FDA, there are a lot of partners in it. So ASPR is this massive portfolio, but the core is, how are we preparing our hospital system? So many fewer capabilities on this side. ASPR HPP has 4 capabilities. Foundation for healthcare and medical readiness. So does a community have a sort of strong, resilient healthcare system? Capability 2, healthcare and medical response coordination. How well does the jurisdiction coordinate across that system? Capability 3, continuity of healthcare delivery. So can the system provide uninterrupted, optimal care in the face of damaged healthcare infrastructure? So think of something like a hurricane. So certain hospitals are underwater. Can we reroute and balance to provide, essentially a similar level of care? And finally, medical surge. One, the demand for healthcare services exceeds the available supply. Can healthcare organizations deliver timely and efficient care? So you need to make sure that you can operate at a regular sort of healthcare level. There's a surge response, 30% or so above that folks need to be able to go into. After that, people start getting rid of patients who have non-urgent services in place. And finally, hospital systems might go to crisis standards of care. That is, they might go into sort of a triage mode where they're not able to give every patient an optimal level of care, and they have to make tough choices. We'll come back to that in the 4th talk. So these 4 capabilities together are what ASPR is really focused on in terms of surging the ability of healthcare to provide the best medical services for folks, even in either disasters or a pandemic. Now, they do this through a set of healthcare coalitions that are based in the different sort of ASPR regions around the country. So these HHS regions, the country is divided up geographically, obviously. Within them, there are a set of medical coalitions that are in place that now are supposed to have hospital as well as primary care and other partners. And those coalitions are the groups that are working with ESF8 generally. As you know, EOCs are divided into emergency support functions. At a federal level, Emergency Support Function 8 is the Health and Medical Emergency Support Functions that does this kind of healthcare coalition. Has different names and sometimes numbers in different places. But essentially, the Medical Coalition is the group of healthcare entities that work with their jurisdiction's ESF8 structure to ensure a coordinated medical response. Now, in the Trump administration, the current ASPR, Dr. Bob Kadlec, put in place a new set of systems, a regional disaster hospital system. His experience was, and he had been ASPR before he worked in government in the Bush administration, he was sort of a founding member of this work, was that, every hospital can't get to the level that you need to care during an emergency. They're just not capable. We have a wide range of hospitals in this country. And especially based on Ebola showed us that having a few hospitals on point who had really significant infection control, isolation parameters would help us to sort of contain a threat nationally. So can't resource everybody, but can we focus on a few core hospital systems to really surge to provide that kind of backbone for the whole nation? So this pilot program was funded to grow on the healthcare preparedness program, to kind of grow this set of superstar entities. So the idea was every region partnered with hospitals and healthcare facilities in that region, chose some specialty care areas, built out a better regional medical response coordination. So it might go outside the ESF8 of that municipality or even of that state to join a couple of regions together. So think about the New York, New Jersey, tri-state area. Disasters don't respect geographical borders, right? So you want to look at clusters of folks and make sure they're being well served. And then you want to make sure that you can measure preparedness across that entity. So if you look at this map, it's helpful to understand where this is coming from. I mentioned Ebola, talked about it a couple of times. After Ebola, the federal government, as I mentioned, funded some regional Ebola and other special pathogens, sort of special hospitals that were given funding to build isolation wards to make sure they could care for Ebola patients or other patients with a discrete set of special pathogens. The triangles there are the regional centers that were chosen to provide coverage around the country. Now, the regional pilot program we're talking about grew out of this idea that we surged some for Ebola. Now let's do that more generally and really build that musculature. And this is how it works in terms of regional healthcare delivery. This is from one of the pilot programs, because remember what's happening now is ASPR has funded a few different pilots to see how it works. This is from the Massachusetts approach, I believe. Now, the way this works is, if you look at this from left to right, it's kind of a right of boon scenario. You have an event that happens. The first thing that happens is pre-hospital care. That means that you are triaging people at the scene, and they're being routed in different ways. The group that's being routed sort of up towards the top of the graphic are victims that either can be treated at home or they can go to outpatient care, right? These are your victims with lacerations, cuts, scrapes, that kind of stuff. Or in a pandemic scenario, they were contacts, but they didn't get disease or they had mild illness, that kind of stuff. Then on the other side, you're triaging event victims that go to a hub hospital. These are the hospitals that are close by that have a couple of functions. They are there to treat patients, certainly, but the idea of a hub is that they also serve as kind of a secondary transport system. Now, this is important because EMS, or emergency medical services, their charge usually is to take the patient from a site of an event to a hospital. That's their role. That is why they call it pre-hospital care. But in this model, you're adding another step in certain massive disasters where you would need to do secondary transport of patients from an initial hub hospital to either an alternate care site. If you have something like a federal medical station set up, that's what happened, for instance, at the Javits Center during COVID, or you would send them to a spoke hospital. These would be a set of other hospitals who have specialty care areas, maybe these regional disaster coordination centers that we've been talking about, and they would take in the patients and they would give them special care. You also might transfer patients to long-term care, so somewhere like a nursing home or something else like that, or you might transfer them out of the state or the region. In certain special pathogenic examples, the country only has a few facilities that can treat those. Ebola, again, is a primary example. And so you may have patients that are really being transported across the country. So the idea of this conceptual framework for regional healthcare delivery is it takes you all the way from the point of the event through any number of treatment operations, and it starts to treat the entire healthcare system as one unified entity. So that, let's see if I can bring my face back here. That's kind of the problem, which is one of the key things about both the public health preparedness capabilities and the optimal framework the National Academy showed us, as well as the healthcare preparedness capabilities under ASPR and the new regional disaster pilot program, is that they all treat this healthcare system like one entity. And famously, the United States healthcare system is nothing like one entity, right? It's sort of like 1,000 different private sector organizations plus some public ones all bumping together that don't want to share data. And that's a problem. One of the key sociological issues in disaster response in the United States concerns federalism. In other countries, in Australia, Great Britain, France, New Zealand, but even places like South Africa around the world, they've learned that in order to respond to disasters appropriately, the country needs to work as one unified entity. And so all of their playbooks and procedures are kind of built around that. In the United States, we have a federalist structure. That is that all of the states work as separate entities, and the federal government is a coordinating entity. I don't mean in terms of disasters. I just mean generally, right? The states are supposed to be the locus of most functions, and the federal government handles coordination with foreign actors. It taxes across state lines, all that kind of stuff. Obviously, the power of the federal government has grown, but still, our conception of a disaster is the disaster is local, right? The disaster is handled locally. The state supports the locality. The federal government supports the state. That means that the ball is called at the local level. There's a lot of good stuff about that, right? It means that the people closest to the disaster get to make the most decisions about it. But there's some tricky stuff. And that tricky stuff really does come into play when you have to coordinate between jurisdictions, when you have four towns near each other responding to the same earthquake in the same way, 4 cities near each other responding to the same hurricane in different ways. But it's really a problem in a healthcare response because even in one town, you may have 3 or 4 different healthcare entities, and they do not all want to work together in the same way. And because of federalism, you also have different states that regulate healthcare entities differently. So you have different capabilities and different responsibilities state to state. The reason this is a sociological issue and not just like a procedural issue is because people in a disaster suddenly seem to flip from wanting to think about localization, to think about their place as unique, to wanting to think of everybody working in a unified way together, right? Disasters are when we come together for the common good. We have a government that's designed not to get too much in our way day to day, right? That's how the United States is designed. We want to be empowered individuals living our private lives safely. And famously, that doesn't really work in emergencies that well. In emergencies, you need a government that is suddenly sort of all powerful enough to support everybody. This has been written about a lot in disaster sociology. Kathleen Tierney, Thomas Drabek have kind of gone through this sudden desire in emergencies for the government to be sort of bigger and stronger than it is. In healthcare, we're really presented with the optimal expression of this problem, which is that it's not just that you have different towns with different procedures and ways of framing EOCs. You have healthcare entities that are actively competing with each other. They are trying to put each other out of business because they're making a buck by treating patients. And suddenly you have to flip them to working as one coordinated entity in disasters. Structurally, that is very difficult. And it's one reason that the healthcare capabilities, although they've been around for 7, 8 years now, haven't made a significant dent in how healthcare operates. Certainly, there are more coordinated entities now. Health and medical emergency support functions are much stronger, but nursing homes are still competing against each other. Primary care sites are competing against each other. We have not yet figured out how to change the response DNA of healthcare from a privatized competitive function to a collaborative community-oriented function in a disaster. As a public health emergency manager, leaving aside all the debates about single payer and Medicare and what's best for the country, I am really jealous of Great Britain's National Health Service. I'm jealous because they can respond as one coordinated entity, town to town, kind of the way FEMA can because of its grants to states, sort of at that level. Whereas I have yet to see a healthcare system in a town or region really act like one collaborative entity. Although the coalition model is moving us more and more in that way. So in the next talk, we'll talk about some of the outcomes of this problem and how that's played out during COVID. And then we'll finish off talking about some of the ethical dilemmas that it creates. So I will see you then.